Hello, my name is Alina Fong. I am a clinical neuropsychologist.
Hello, my name is Jaycie Loewen. I'm a clinical neuroscientist.
Today, our presentation will be on the neurologic, cognitive, and social effects of COVID-19 on survivors and caregivers. For today's presentation, my goal is to cover these following topics, including COVID-19 infection pathophysiology, discussing direct and indirect effects of the virus, discussing acute and chronic symptoms, and also the neurological implications of the infection. I would also like to go over whether or not we categorize COVID-19 as an acquired brain injury. I would like to present a case study of a COVID-19 patient that came through our clinic with chronic symptoms. Implications of dysregulated brain function after COVID infection, and ask the question if whether TBI survivors are more at risk for COVID-19 infection or symptoms, and what we as clinicians, caregivers, and survivors should know for the future. COVID-19 is unique in its ability to affect multiple systems in the body via either direct infection or mechanisms or indirect mechanisms like reduced oxygen or increased inflammation. In this figure by Wu et al. From this year, we can see, for example, on the left, how direct infection can cause injury to vascular systems and lead to issues with increased interleukins and damage to the blood-brain barrier, which is supposed to keep our brain protected from invasion, from things like viruses and bacteria. Given that COVID can also cause direct neuronal injury and demyelination, this is extremely important. Paniz and Mondolfi et al. April 2020 also showed evidence indicating the neuroinvasive nature of the virus and the likely routes of transmission to the central nervous system. There is conflict currently as to which aspects of COVID pathophysiology may be more important. Some researchers and clinicians are more focused on the potential overreaction of the human immune system, whereas others may be more focused on the oxygen uptake and distribution. Thankfully, I'm not here to enter into that debate. Rather, I want to discuss an organ that can be harmed by each of these pathways, which is the brain. Let's take a deeper look into the direct pathway. A group of researchers indicated that a particular cell receptor, angiotensin-converting enzyme 2, ACE2, is likely the cell receptor of the COVID-19 virus, which is also the receptor of the SARS-CoV and HCoV-NL63. ACE2 receptor is highly expressed in various body organs. This current study from Karaji et al. 2020 highlights its expression in the nasal and oral mucosa, especially the tongue. These organs could be potentially high risk for COVID-19 infection. This study explored 2 public genome databases and performed single-cell transcriptomic analysis to examine and validate the expression of the ACE2 receptor on oral mucosal tissues, the tongue more than buccal and gingival tissues, and on epithelial cells and lymphocytes. Because high expression of the ACE2 receptor was also found in the colon, consistent with other reports of GI involvement in COVID-19 infection, a fecal-oral route of transmission may also be possible, in addition to the oral and respiratory. Furthermore, the reported altered sense of smell or anosmia and taste, dysgeusia, in patients infected with COVID-19 may be explained by the presence of the ACE2 receptor on tongue and nasal epithelial cells that might help mediate neurotropic or neurovirulent mechanisms to modulate taste and smell pathways. Because COVID-19 may be more easily detected in saliva than swabs from the nasal pharynx, the oral cavity is a critical site for the study and prevention of COVID-19. The ACE2 receptor is one target being explored for therapeutics.
For the indirect pathway, we need to consider how the COVID virus can induce changes in physiology that lead to things like, for example, hypoxia, which then changes the amount of oxygen available to neural tissues. COVID is unique in that its pathway through ACE2 receptors can affect a number of different organ systems, which we will discuss in the next slide. However, briefly, we need to discuss how COVID can cause hypertension, coagulopathy, and immune-related neurologic injury. Recently, Chang et al. Have put out a in peer review publication to be published this year discussing how COVID infection can actually lead to autoimmunity and possibly trigger a disease similar to multiple sclerosis. Most importantly, we need to discuss the potential for chronic injury even after the acute infection has been cleared, whereby there might be reduced clearance of post-infection debris. Next, we'll go on to complex organ damage.
Now let's look at organ damage from COVID-19 infection. COVID has known effects on multiple organ systems, which is likely why it's the cause for its wide range of symptoms. Some symptoms affected include the heart. So imaging tests taken months after recovery from COVID-19 have shown lasting damage to the heart muscle, even in people who experienced or reported experiencing only mild COVID-19 symptoms. This may also increase the risk of heart failure or other heart complications in the future. Next is the lungs. The type of pneumonia often associated with COVID-19 can cause long-standing damage to the alveoli, or the tiny air sacs in the lungs. The resulting scar tissue can lead to long-term breathing problems. Liver. Individuals on medications, such as survivors of traumatic brain injury, may be more at risk as their liver is put under even more strain to process medications. The gut is also an area that we're looking into a bit more with these correlative gastrointestinal issues. And for me, importantly, is the brain. Even in young patients, COVID-19 can cause strokes, seizures, Guillain-Barré syndrome, which is a condition that causes temporary paralysis. And it's also linked to increased risk of developing Parkinson's disease and Alzheimer's disease. Taking a direct quote from Aboud et al. From this year, quote, "Currently there is convincing evidence that SARS-CoV-2, the etiologic agent of COVID-19, can affect the nervous system with damage and neurologic alterations. These neurologic disorders are grouped into several categories, ranging from non-specific and moderate symptoms such as headache, myalgia, and hyposmia, to severe symptoms including cerebral vascular disease and intracranial infections," end quote. So directly or indirectly, COVID-19 infection can induce or worsen an acquired brain injury. So as we see here, SARS impacts neural function and supply of blood to oxygen and tissue. So what can we learn from other types of acquired brain injury, and how do we utilize this knowledge to maximize potential recovery for these patients? For additional information or conversation about some of these indirect and direct viral mechanisms of COVID and how it relates to brain injury, my colleague and I actually wrote an article earlier this year. We encourage anyone interested to be able to read that. It was entitled "Encephalitis and Cytokines: When Viruses like COVID-19 Have Long-Term Effects on the Brain." We discuss how viral infections can affect the brain even when they're not capable of crossing the blood-brain barrier. We talk about how COVID-19 could cause long-lasting brain dysfunction, and whether PCS patients or post-concussion symptom patients should be considered high risk. There's a call to action about how to be proactive about COVID-19 and what to do if you don't feel like yourself after experiencing the infection yourself.
There are a range of symptoms for COVID-19 infection, both during the acute phase, or when the individual is infected with the virus or maybe dealing with acute issues coming from the viral infection, as well as those that are present in more chronic patients or individuals that have begun to call themselves long haulers. To compare and contrast, many may know that acute infection may come with fever or chills, cough, loss of smell or taste, as well as some GI-related issues, headache, and another of other symptoms. Chronic symptoms are a little more unique and not as discussed currently. Many patients experience what is now called COVID fog or brain fatigue or brain fog. They may have persistence of headache and dizziness, still have loss of smell and or taste months after the acute infection, mood disorders, muscle weakness, and many more, which we will now discuss based on research done by Dr. Lambert and their survivor corps. So you may be asking, who are the survivor corps and who is Dr. Lambert? Well, Dr. Lambert in this group of long haulers or individuals that have had COVID and are still experiencing symptoms, sometimes months to over a year out, have formed a force within which we are conducting research and trying to figure out why certain individuals may still have poor quality of life due to these long-standing symptoms, even though they have passed the acute stage of infection. So we have to ask ourselves, when is someone considered a long hauler? This is still a question up for debate. Many individuals will go months and months with some symptoms persisting, maybe some symptoms resolving. However, there are individuals who we know that have seen no relief despite receiving different medications or evaluations with practitioners. There's still a lack of research right now. We don't know how many long haulers there are out there. This can also combine with the lack of criteria. However, as of July, the CDC reported 35% of symptomatic adults who had tested positive for COVID said they had not returned to their usual state of health 2 to 3 weeks after their tests. Now, as we have discussed with the physiology of COVID, this could be due to impact of the acute infection on multiple different organ systems. However, there is suspicion that even after multiple systems register as normal, there may be persistent functional challenges in different organ systems, including the nervous system, long after the infection has cleared. Unfortunately, there is a lack of support. Many doctors do not know what to do with these long haulers, or in some cases do not believe them. This can lead to significant policy and insurance issues for patients that are still seeking relief. So where do we go from here? We have had the privilege of connecting with the survivor corps, meeting with them, and have found that our interests in figuring out solutions for these patients are in line. As we will be discussing later, with not only the symptoms that these long haulers present with, but many of the aspects of COVID, including the autonomic nervous system and the brain, are very similar to what we deal with concussion.
An additional complication is that the CDC report of long hauler symptoms appear to be very different from the symptoms that the long haulers report themselves. While the impact of COVID-19 on the lungs and the vascular system have received some media and a lot of medical attention, the results of this particular survey suggest that brain, whole body, eye, and even skin symptoms are also frequent occurring health problems for people recovering from COVID-19. The Survivor Corps group study frequently reported reaching out to primary care doctors for help managing lesser known and more painful symptoms, but that some of their physicians were unable or unwilling to help patients manage these due to a lack of research about these other more lesser known symptoms. A reported 26.5% of symptoms experienced by long haulers are described as painful by these group members in the Survivor Corps. Let's discuss a bit about the neurological effects of COVID. Multiple studies, from single case studies to larger nationwide research studies, have now shown that COVID has significant neurological implications. Some suggest the current estimation of people infected with COVID who display symptoms is far too low, and those with even mild symptoms or even maybe asymptomatic may not avoid neurological complications in the future. In Figure 1 on the right, this is taken from Lal et al. 2020. And this displays how the location may have different symptom manifestations. So for example, central nervous system is more correlated with headaches, dizziness, cerebrovascular disease, epilepsy, encephalopathy, and ataxia, whereas the peripheral nervous system is more associated with the loss of taste, hypogeusia, the hyposmia or loss of smell, and neuralgia. Additionally, some doctors have seen evidence of a sympathetic storm in some patients, which is a hyperreaction of the sympathetic nervous system that can cause these seizure-like symptoms and is most common after a TBI. Plant et al. In 2020 further investigated acute neurological and psychiatric complications of COVID-19. Altered mental status was one of the most common presentations, comprising encephalopathy or encephalitis and primary psychiatric diagnosis, often occurring in these younger patients. So what do we know? We know that COVID can affect the brain and it can cause symptoms that mimic brain injury. But what is the cause, and how can we detect the cause in patients that show no structural brain or nervous system issues? Well, this is not a new problem. For those of us in the concussion world, mild TBI or concussions are injuries that are also considered invisible on CT and MRI. However, with advanced neuroimaging like diffusion tensor imaging, fMRI, arterial spin labeling, SPECT, etc., we are able to detect dysfunction in spite of normal, quote-unquote normal, structural brain imaging. My research is in fMRI, and we and my colleagues here have published articles showing that neurovascular coupling dysfunction is involved in a number of cognitive and neurological disorders, from neurovascular dementia, epilepsy, migraine, brain toxicity, etc. So briefly, neurovascular coupling is a process by which our vasculature provides accurate, precise, and plentiful blood flow to our neurons during activation. NVC, or neurovascular coupling, provides a rapid and sustained source of oxygen and other energy metabolites for our neurometabolic needs. Injury to neural tissues can decouple or uncouple this process, sometimes for months to years. When decoupled, the regional energy supply does not equal the energy demand. So this leads to neurometabolic imbalance and inability to provide substrates for healing, which can lead to chronic symptoms. At our clinic in Provo, Utah, we utilize task-based fMRI. We have adapted 6 different neuropsychological tests to the MRI machine, and each patient undergoes all 6 of these tests, which include a matrix, a reasoning test, trails A and B, a picture naming test, verbal fluency, memory, and a face recognition or visual memory task. We then analyze over 60 different regions of the brain and can provide sensitive and specific regional data, as well as an overall severity index score. But fMRI isn't just useful for detecting brain injury and functional changes in concussion, but also these other injuries like more severe and moderate traumatic brain injuries, stroke, tumors, hypoxia and ischemia, infection, encephalitis, meningitis, and even chemical pharmacological issues. More importantly, from a clinical standpoint, it can be used for targeted multimodal treatment. So our results show that an fMRI targeted treatment approach can drastically reduce chronic symptoms resulting from brain injury. So in this figure, the bar graph on the left is displaying an overall SIS, or symptom index score, severity index score of 3.29. The higher the score, the more neurovascular decoupling or dysregulation is seen on fMRI for that patient. The SIS score on the right shows a 2.8, which indicates normal neurovascular coupling functioning for a control. So keep in mind, this SIS, or severity index score, is an overall aggregate score which we use clinically to quickly assess the severity of neurovascular coupling or decoupling in a patient. but it does not specify regions of the brain that may be affected. It's like looking at an overall GPA versus knowing exactly what grade you got in OChem. To use the same analogy, both a GPA and an official transcript from your university would give you a fuller picture of your academic performance. To further break down the SIS score, we have published a paper in 2018 on these fMRI biomarkers, which is more or less our transcript that comprise or make up that overall SIS score. These biomarkers are what allow for specific regions of the brain to be analyzed and allows for tailored treatment for our TBI patients. So we had to ask the question, what would we see in a COVID patient on fMRI? I want to discuss now our case study. We were lucky enough to have the opportunity to meet, interview, scan, and treat the following patient. As background, prior to COVID, he was reportedly healthy, active, high functioning. He, I believe, was an actuary and only had one isolated incident in his teens that might have been a concussion, but with no reported lingering issues or symptoms. Based on his PCSS, or his post-concussion symptom scale at intake, despite no other diagnosis in COVID, he reported the following symptoms, and you can read those in the slide. And for those of us in the business, these are very commonly reported symptoms for PCS and other types of brain injury. But, of course, this wasn't your typical concussion. This wasn't a concussion or your typical brain injury. And so upon other questioning that looked at other symptoms, this is what he reported. Now, again, he contracted COVID-19 in February and suffered in the acute phases of the disease from February to March. His chronic symptoms specific to COVID were whole body weakness and fatigue. He reported also having low energy and crashes after overexertion, and he felt like he was struggling to stay conscious. He had muscle tremors, not painful, but they happened all over his body and would flare up with stress. His brain would feel inflamed. He said that his brain felt swollen, like his brain was sunburned. Sometimes he felt pressure in his head if one spot is swollen. He had chest pain on his left side. In fact, he reported going to the ER, quote unquote, a lot at the beginning, end quote, because of this pain. And it was exacerbated by overstimulation and fatigue. He reported dysregulation of his heart rate, like when he's exercising, it should be rising, but it won't speed up, while on the other hand, sometimes he would be resting after moderate exercise and then his heart rate would jump up. And then, of course, anxiety. He also reported electric zaps throughout his body that would come and go, body pain that moved around for the first 2 months after his illness, and it would be anywhere from his forearms, arms, to his calves, to his feet. He also reported temperature dysregulation in his legs and feet. He would see flashes of light. He had photophobia and phonophobia and sensitivities with temperature. He had sensitivities prior to COVID, but it manifests more physically with panic now. After COVID, he developed heartburn and esophageal spasms. He had to be more careful about what he eats and when he eats. In the acute phase, he lost about 2 to 3 pounds. However, in his more chronic phase, by the time he came to us, he had been consistently losing weight, about 1 to 2 pounds a week in April. He even tried to up his caloric intake to about 4,000 calories a day, which slowed the weight loss, but nothing seems to stop it, still only slowing it. And currently, he's dropped from 153 pounds pre-COVID to 130 now. No findings on structural MRI, which were done June and August of this past year. So we were very curious, what would his fMRI results reveal? Because he reported so many symptoms that were very similar to our TBI patients, but also many symptoms that were not associated with typical TBIs, we were very curious as to what his fMRI would reveal.
Upon reviewing the patient's functional MRI, we saw that their severity index score was a 1.89. Now, the mean severity score for a healthy population is set to 0, as seen on this right-hand graph. That is the middle of the bell curve for a healthy population. Now, the mean severity score for our current concussion patient population is around 2. This is 2 standard deviations away from normal when looking at neurovascular coupling in these patients' brains. Functional MRI further showed dysregulation in subcortical, language, and attentional systems. In conclusion, this patient exhibited symptoms and brain dysfunction akin to other brain injury survivors.
On this slide, we take that patient's SIS score, and I'm showing you one of the 6 tasks that actually contributed to that aggregate score. So this figure on the left shows one of the 6 tasks that the patient completes while in the fMRI. Very briefly, the black lines in the graph indicate how much blood is being metabolized by these different regions that we are measuring. Any activation in the dark blue areas or the dark purple areas are within normal limits. Any above that area in the light blue or the white indicated hyperactivation. Anything below is considered hypoactivation. As you can see here, this patient has significant hypoactivation in the posterior medial frontal cortex, inferior frontal gyrus, and the superior colliculus. This indicates difficulties with sensory motor integration, multitasking, impulse control, eye tracking, visual search, visual processing, memory, and language. Based on these findings, we were able to craft an individualized treatment program for this patient. He participated in cyclical, sustained, and targeted therapies, including, but not limited to, neurooccupational therapy, sensory motor training, neuromuscular therapy, physical therapy, neurocognitive therapy, mindfulness and psychotherapy, Dynavision, neurosensory integration, vision therapy, vestibular therapy, along with built-in relaxation and destimulation. This is founded upon our theory of PAR, which we also published in 2018. PAR stands for Prepare, Activate, and Recover, where preparation includes cardiovascular expenditure, exertion, aerobic exercise. We then activate the brain with cognitive therapies, and we have to build in rests and destimulation. Much of our theory on active therapy is built upon the works of my colleagues John Leddy and Barry Willer over in Buffalo, and we definitely subscribe to a very active route towards healing. This slide presents the patient's actual week-long schedule. These are all 1-hour-long therapies with one-on-one treatment, Monday through Friday. He underwent fMRI imaging on Monday with therapies beginning that day. And then on day 2, 3, 4, therapies were from 9 to 5, basically, every hour, culminating in another fMRI scan and some treatment again on day 5, which was Friday. This was very intensive treatment, very frequent treatment. We crammed about 6 months of therapy into 1 week with this patient. We have the same program for our concussion patients as well, and we see very encouraging results. Now, when comparing his pre and post fMRI, we did find that this multimodal therapy significantly improved his neurovascular coupling dynamics and some of his symptoms. He went from a 1.89 pre-treatment to a 0.14. The patient was still reporting symptoms despite drastic improvements with neurovascular coupling, which led us to the question, why? This was very concerning to our team because when compared to our typical concussion patient, a typical concussion patient can see a 75% reduction in symptoms, both subjectively and objectively with fMRI imaging. And we know that neurovascular directed therapy works. We have seen benefits of targeted autonomic nervous system therapy, vestibular, visual, and other therapies. So why was this patient different? Well, first of all, he wasn't a concussion patient, right? Even though he had many of the symptoms of concussion patients, he also had a number of symptoms that were outside of what we thought were similar to concussion patients. Even after treatment, he still met language and attentional biomarkers and demonstrated dysfunction in a number of memory systems. So many of our other concussion patients overcome these within weeks. However, this person's breathing, vestibular, and overall physical indices were still alarming. We last checked in with this patient on September 15th, and he reported that weight loss is still a huge concern. We have kept in regular contact with this patient, and we referred him to a pulmonologist, a gastroenterologist, an endocrinologist, and we continue to monitor and work with this patient with, of course, the goal of hopefully 100% symptom remediation. So the conclusion is, neurovascular coupling is a key part of the puzzle, but we are still missing some of these pieces. So in summary, COVID-19 can induce changes in brain function that can persist for months even after the virus is cleared. The cause of COVID-acquired brain injury is multifold, including hypoxic and inflammatory damage. And dysregulated neurovascular coupling after COVID-19 can be treated, but other issues may hide improvement in neurovascular coupling. So what does this mean for TBI survivors and caregivers in terms of prevention and management? How do we treat COVID-induced ABI? In order to understand how to treat COVID-19 as a whole, we must first look at the psychosocial effects of COVID-19. Dubey et al. Quotes, "Disease itself multiplied by forced quarantine to combat COVID-19 applied by nationwide lockdowns can produce acute panic, anxiety, obsessive behaviors, hoarding, paranoia, depression, post-traumatic disorder in the long run." Dubey goes on to state that adverse psychosomatic outcomes are nevertheless expected to increase significantly due to the pandemic itself, and also due to constant flow of readily available information and misinformation and reinforced messaging obtained via online social networking services of almost all forms. These psychological effects have been fueled by an infodemic spread via different platforms on social media. Consideration for involvement of effects such as irritability, fear of contracting and spreading infection to family members, anger, confusion, frustration, loneliness, denial, anxiety, depression, insomnia, despair, and fear to extreme consequences, including suicide, must be considered. But I believe there are ways to combat this. The COVID-19 pandemic and quarantine have created challenges for people all across the world. This is perhaps especially true for our TBI survivors and their caregivers who are already dealing with the physical, mental, and emotional consequences of brain injury. While some TBI survivors may initially find following COVID-19 restrictions not so different from their daily lives, the increased effects on psychological health, relationships with family and friends, and lifestyle patterns can have noticeable long-term consequences. We were able to publish an article in the United States Brain Injury Alliance Summer Newsletter about tips for the summer of COVID with a brain injury and beyond. In this article, we addressed some of the biggest issues COVID-19 and the quarantine may be causing TBI survivors and give you tips on how to manage these issues. They centered around mostly mental, physical, and lifestyle strategies. In the mental area, we espoused and encouraged meditation, mindfulness, even journaling with a gratitude journal. Physically, we encourage people to get outdoors more safely, of course, and in a socially distanced way. Maintaining good exercise and regular exercise, yoga, stretching, things like taking a bath, and maybe even trying PMR or progressive muscle relaxation. And in the lifestyle category, implementing proper sleep hygiene, educating yourself on what sleep hygiene is, maintaining a healthy diet and nutrition, and very importantly, keeping up social connections, either with phone calls or video calls, writing letters, meeting up in a park, maintaining social distance. But these are just some very practical ways that we need to engage in order to stay healthy, mentally, physically, and socially.
So we are aware that brain injury can involve issues in interrelated systems. These can include how the autonomic nervous system, which is in control of blood flow, can also interact with issues with neurovascular coupling, or the relationship between neuronal activity and blood supply. Interestingly, we are now finding and learning more about how COVID, which acts through the ACE2 receptor, can directly affect blood flow, as ACE2 is one of the key components in this pathway. Therefore, COVID-19 can not only affect the blood-brain barrier, but might directly be able to affect neurovascular coupling in the acute stages of infection. Now, we have to ask the question, not only are brain injury survivors more risk for COVID infection-induced sequelae, but what about their risk for infection? As per Public Health England, a report published last year, they have found that individuals with learning disabilities are more at risk for infection and death from COVID. For many brain injury survivors, they are suffering with cognitive or learning disabilities. Therefore, they may also be more at risk for infection and death. In addition, certain medications brain injury survivors are on may increase the risk for immune dysfunction or interaction and some types of organ damage. Finally, and as we're going to discuss in the following slides, we're very concerned with symptom stacking. For example, we know COVID-19 can cause changes in how our organs function, but what about when COVID-19 can cause both hormonal imbalances leading to mood disorders, alongside someone suffering from PTSD from a long-term stay in the ER, the intensive care unit, long-term care? These are things we need to discuss, not only for understanding the cause of these symptoms, but for appropriately and fully resolving them in each and individual patient.
COVID-19 and hormones. We already know that TBI survivors are more at risk for hormonal disruption. Different endocrine glands or organs that can be affected by COVID-19 include the pituitary. There's possible hypothalamic pituitary dysfunction and alterations in antidiuretic hormone metabolism. Next is thyroid. Sick euthyroid syndrome is a possibility. Adrenal. There's probability of higher susceptibility to COVID-19 in adrenal insufficiency and possibly Cushing syndrome. Bone. Low vitamin D may be linked to more severe disease and increased risk of hypocalcemia. Testicles. Higher susceptibility and worse outcomes have been reported in men. Diabetes. Worse outcomes in diabetic patients. And then also obesity. There's a worse prognosis in obese patients. Brain injury survivors and caregivers are more at risk for psychological diagnosis. So I want to talk about the psychological impact of symptoms of brain injury on COVID-19. 1 in 5 individuals may experience mental health symptoms up to 6 months after concussion. And this is from the TRACK TBI study. Post-intensive care syndrome for the family, or PICS-F, is a constellation of depression, anxiety, post-traumatic stress symptoms, and complicated grief that can occur in family members of patients that have been in intensive care units. Also, both the central nervous system and the autonomic nervous system are likely involved. Our patients with coincident diagnoses of anxiety and or depression experience significantly higher symptom load despite similar rates of neurovascular coupling improvement. So brain injury survivors and caregivers are both more at risk for psychological effects of COVID.
Our clinic has recently come up with a master checklist for brain injury patients that may come to us with COVID infection or for long haulers. With so many systems affected by COVID, comprehensive testing is essential to determine where persisting symptoms are coming from and how to address them. In addition, issues with one system can interact with issues from another. Briefly, we assess the psychological aspect as was discussed in the prior slide. Evaluation and support for mental health of the patient and the family. Potential cognitive behavioral therapy and family counseling may be essential for a patient to fully feel the effects of any physiological change in their body. Hormone issues, testing for blood, urine, and others for adrenal, gonadal, and thyroid, amongst other hormones, may be essential to determine whether somebody's dealing with, for example, hypopituitarism induced by COVID. Gastrointestinal. As we have learned, many individuals with COVID have changes in their gastrointestinal system, including possible leaky gut, changes in what foods they can eat, and what nutrients they can absorb. If nutrients aren't getting into the bloodstream, they're not going to get to the brain and allow for healing of other organs and tissues. Pulmonary. Our lungs are the way by which we get oxygen, which then goes to our brain and other systems. It is essential that patients are educated on diaphragm dynamics. We make sure that their oxygen and CO2 balance is appropriate and that we're not fighting against lung scarring and inflammation. Recently, we have also discovered the importance of the autonomic nervous system, not only in the chronic infection, but in the acute stages. Recently, there is a clinical trial that has come about investigating a vagal nerve stimulator for acute respiratory distress syndrome, or ARDS, in COVID-19 hospitalized patients. The mechanisms by which we may be able to activate the autonomic nervous system, specifically the parasympathetic or rest and digest side, may be able for us to prevent long-standing brain damage from hypoxia or other type issues. And finally, neurovascular coupling. As we have shown here, functional MRI is able to indicate where there may be dysfunction in different brain systems, even in patients that may have had other diagnostics done, including structural MRI showing no issue. We would like to briefly update on the situations as far as vaccines. As you likely know, a number of vaccines are already available on the market, which are showing a resounding success. For example, Moderna and Pfizer-BioNTech already have vaccines available on the market that are showing up to 95 or more % protection in individuals that have received both doses of the vaccine. And currently, if you look at this graph, we can see that a number of different companies are investigating not only vaccines that work like the Pfizer, BioNTech, and Moderna, but also work in different manners. For example, vaccines can work through viral vectors, subunits, or viral fragments, as well as injection of weakened or inactive versions of the virus. Hopefully, in the upcoming months, we will see new vaccines hit the market that may both protect individuals from contracting the vaccine, as well as protecting individuals by preventing transmission. There are obviously pros and cons to each vaccine, and we recommend, if you have had a brain injury and are interested in receiving the vaccine, to discuss this with your primary care physician, and if you have been asked to participate in a clinical trial, to notify the trial conductors that you have a brain injury. So where does the brain injury community go from here? We hope that through this presentation you appreciate how COVID-19 could act as a novel type of acquired brain injury, not only through indirect mechanisms, but through direct infection of neural tissue. Unfortunately, we are now seeing new variants arising that pose a significant risk due to mutations that allow easier entry into cells, higher binding affinity, and other mechanisms by which these COVID variants may lead to higher rates of infection and possibly death. This leads us to discuss the cognitive, visual, physical, and other symptoms caused by COVID and their direct physiological connection, not just connections to potential psychological changes caused by this recent epidemic. Resolving chronic symptoms from COVID-19 will require the participation and collaboration of specialists from numerous fields, in addition to an individualized and specific approach for each patient.
But the most important thing that I want to end with is hope. If you search the term COVID-19 on clinicaltrials.gov, there are now, as of today, which is November 12th, 2020, over 3,800, almost 3,900 publications of clinical trials, which included studies ranging from evaluation of small molecule pharmacotherapies, mesenchymal stem cells, or T-cell-based therapies, convalescent plasma therapies, immunoglobulins to medical devices in the treatment of COVID-19. And that's an excerpt from Gupta et al. 2020. So much research is being done, with so much more research to be done. I would like to thank you so much for your time and attention today, and I hope I have shed some light on this subject for all audiences, I know, including clinicians, researchers, survivors, and caregivers who are listening. I know that with the rapid rate of research surrounding COVID, this information may be outdated in a few months, and I look forward to the opportunity to speak again on this subject. And thank you again for your attention, and have a great day.